Okay, I've already mentioned what we're going to talk about, so we'll move on. No significant disclosures for me. So initially, I just wanted to give you a couple quick facts about brain metastatic disease, just to make sure we're all on the same page, and to kind of give you a perspective of what I think about when I'm taking care of these patients. So the incidence of these tumors, 7 to 14 in 100,000. And just to put that in perspective, our most common primary malignant tumor is GBM, or glioblastoma. And brain mets are clearly much, much more common for us than this malignant primary tumor. So 20 to 40,000 brain metastatic patients per year, much more common than those GBM patients. The prevalence rates really range based on the studies that you look at. It might go from 10% up to 30%, but I think it's probably higher than that. In 2008, American Cancer Society said that 40% of cancer patients are going to have a brain metastatic disease that is going to be clinically important that we're going to have to deal with. Clearly, in my practice, I'm seeing more of these patients nowadays than I did just a few years ago. Lots of discussion in the literature about that, lots of good reasons. So clearly, we're impacting long-term survival for a subset of cancer patients, so that might be why. In neurosurgery, it seems like MRIs are so easy to get. You know, if you stump your toe and your foot hurts a couple weeks, you're going to get a brain MRI. So all my patients, they show up with their MRIs in hand. And I emphasize that because nowadays I do feel like I'm seeing more patients where I'm making the initial diagnosis of cancer for that patient because of an asymptomatic finding on their brain MRI. And there's lots of interesting discussion in the literature about how our evolving chemotherapies might be sort of selecting or predisposing patients who are living longer to show up with a brain met that we're going to have to deal with later on. I wanted to just show you a couple of key things from this interesting work that recently came out looking at changes over time, and it illustrates a couple important points for us as clinicians taking care of these patients. So 20 years ago, clearly, lung met was the predominating brain met, as it continues to be today, but we're seeing less of that. So fewer of those nowadays, and we're starting to see a few more of these other brain mets, like renal, colorectal, and melanoma. So as a surgeon, these are brain mets that I'm not quite as familiar with operating on as I am a lung met. So they are, this changing landscape is providing some newer challenges for surgeons. So nowadays, we're seeing more patients with multiple brain mets than we did 20 years ago. Lots of good reasons why, but as you can imagine, it makes it a much more complicated patient for a surgeon to deal with. Nowadays, we're seeing a lot more patients who have had radiosurgery. And so that creates additional questions in our mind when they show up with an MRI showing changes that we're haven't quite figured out how to interpret and what to do in those patients. And my hope is that one of our speakers will kind of jump into that discussion a little bit. And unfortunately, we still are not getting most of these brain metastatic patients additional post-operative therapies. We're doing better nowadays, but still the majority are not getting additional therapies, and there's lots of good reasons for that. So another important point from this nice study is that over time, median survival has improved if you throw all these together. What's even more exciting is that if you look at longer-term survival, so for example, 1 year out, survival has more than doubled. So clearly, we have not found the holy grail for taking care of brain met patients, but there are a subset of these patients, and if we do a good job and pick the right patient, we can have a huge impact on survival. Clearly, those patients who are getting surgery have a median survival much better than they did compared to those 20 years ago. And then another important point here is that when you look at classification systems that take into account their functional status, it's a very, very important thing for us as surgeons to keep in mind. RPA is probably the more familiar, longer classification system that we look at with brain mets. It looks at various variables, for example, age, number of brain mets, but most importantly for me, it looks at their functional status. So class 1 would be the best functional status, and those patients have a much better median survival or long-term survival after surgery for brain met than compared to the lower classes, and certainly compared to those who were getting treatment 20 years ago. A couple other important facts. So we think that brain mets largely get to the brain by hematogenous spread. So what that really means to me is that the vast majority of these occur in the brain parenchyma at that gray-white junction. And that gray-white junction is right there between the cortex and the subcortex, and that's only about 6 millimeters below the surface of the brain. So that is a very accessible region for a surgeon, and that's the majority of brain mets. There are some other important things we have to keep in mind. So for example, some mets like melanoma are very hemorrhagic, making surgery a little bit challenging. Some are more radiosensitive than others, and that is also starting to kind of sway how we're treating these patients. By and far, the vast majority of brain mets are supratentorial, they're up in the cerebral hemispheres, and really for the vast majority of those, they're surgically accessible. Just a word about imaging. So if you have a solitary brain met on CT, you most likely are going to have multiple brain mets. So 2/3 of people will have multiple mets on a brain MRI, and most likely that's going to preclude surgical treatment. So we basically use MRI for our preoperative imaging, and the point I want to emphasize here is that out of all the different types of MRI imaging that we're looking at, they have unique characteristics for metastatic tumors, but they're the same characteristics if you're looking at something like a primary malignant glioma like GBM. I didn't put it on the slide, but there are also the same imaging characteristics for something as different as a brain abscess. In a lot of series in the literature, people who go into the operating room with a high clinical suspicion of a brain met, at least 10% will come out with something as different as a brain abscess. So very, very important to keep that differential diagnosis in mind as we're having patients live longer and we're following them over time with a lot of imaging. There's lots of other imaging modalities that we use sporadically. None of these really are part of the standard of care quite yet, so I'm not going to get into those details. Now, I've been arguing that pretty much all brain mets ought to be surgically accessible. Sometimes they do occur in areas that are a bit tricky. So for example, if they occur in an area that we call eloquent. So an eloquent area of cortex would be a part of the brain that if we injure it, then they're going to definitely have a significant functional decline or neurologic deficit that's going to greatly alter quality of life. So we don't do it. So as an example, here's a nice brain tumor right next to primary motor cortex. Here's a nice brain tumor in the left temporal lobe, so we're thinking about speech centers. 20 years ago, a little bit challenging to deal with those. Nowadays, it's really standard of care in any neurosurgical operating room to be able to deal with those. So we can use fancy tools to make sure we get those out and not injure that eloquent cortex. And I'll show you a couple examples of those tools. So for example, here's that left temporal patient. Here's the left temporal lobe that's been exposed in that speech center area. I can pull out simple stimulating devices like this and map out where that speech is so that I can stay away from it. Another standard of care tool nowadays is neuro navigation in the operating room. Here's an example of an instrument device that we can bring into the operating room and just using simple probes navigate to exactly where that tumor is so that we can get right up next to those eloquent cortices and not injure them when we take out these tumors. And lastly, a very exciting intraoperative tool that's coming online that's pretty common now, and my guess is in 5 to 10 years will be standard of care, is giving patients preoperatively a marker that will localize to the tumors and then will fluoresce intraoperatively. So here's an example from some of the research that I'm doing in my lab looking at very specific markers. And on the right, you can clearly see tumor next to normal brain. And then over here on the left, you can see how you can clearly see what's fluorescing and what's not. So another tool that really helps us take these tumors out and save the nearby adjacent brain. So you can't have a discussion about surgery for brain mets without knowing about this work. And this is a 1990 work from Patchell that really was the first randomized clinical trial saying that surgery for brain mets works. We haven't had many randomized clinical trials since then. And so this work, even though it's old, 1990 is clearly not the modern era nowadays. But this work emphasizes some key points that we still base a lot of our decision-making on. So I think it's important to illustrate some of those. I'm just going to skip over some of these details for the sake of time. So median time to recurrence of a brain met in this randomized clinical trial study, significantly longer in those who got surgery versus those who did not, 60 weeks versus 20. Overall median survival, significantly better in those who got surgery versus those who did not get surgery and only got radiation therapy. Median time to death due to a neurological cause, significantly longer if you got surgery versus those who did not. Median time with a KPS of greater than 70, significantly better if you got surgery. KPS is Karnofsky Performance Status, so that's just a very common clinical tool that we use to kind of assess their functional performance status. And 100 would be a normal person, but 70 or greater basically means you're independent. You can pretty much take care of yourself. Those last 2 points are really, really important to us. So the literature has been pretty robust at supporting those last 2 points, and that is by taking out these brain mets, we can significantly impact death from neurologic cause. We can significantly impact a longer-term good performance or good functional status for the patient. Even though this data supported that we can impact overall survival, I think there's been plenty of data to say that we don't have quite as strong as an impact on overall survival of this obviously systemic disease. So as a surgeon, we're really looking at that neurologic problem and how we can fix that and maintain a good functional status. So can we keep that patient walking? Can we keep their dominant hand working? Can we keep them speaking? So bottom line from that work was that surgery was a benefit in patients who had a single brain met, who had relatively well-controlled systemic disease and had a reasonable life expectancy of at least 2 months. Nowadays, we're not quite as liberal with that life expectancy. We like to see a life expectancy longer than that, and I'll get into that in just a minute. Since then, there have been a few other RCTs in the 1990s. Here are 2 examples. So here's a similar size study. Importantly, it also showed that median survival was significantly different, so those who got surgery did better than those who did not. Here's another study, RCT study, similar size, etc. They did not see a difference in median survival, but importantly, they emphasized that a patient who has good control of their extracranial disease is a good patient for surgery. And if they don't have a good prognosis, good control of their extracranial disease, then we need to rethink operating on those patients. It wasn't until 2010 that the neurosurgery organizations out there came up with guidelines. So AANS and CNS, those are the 2 primary neurosurgery national organizations. And they finally started putting out practice guidelines for us surgeons to follow in 2010. And in a nutshell, they said, yes, there's level 1 data to operate on the right patient. Yes, there's level 1 data to follow that up with whole brain radiotherapy. At that time, the question was still out about SRS, stereotactic radiosurgery, so didn't have level 1 data to support that guideline at that time. My guess is we're going to hear more about that a little bit later. So I'm just going to pull up a couple good pieces of data that came out this past year, looking at brain mets and surgery for those. So here's a reasonably good size study. It's a retrospective study. It's a surgical population, so there are lots of caveats of looking at that data. I'll just point out that one of the exclusion criteria was small cell lung cancer. So I've already mentioned that earlier. So that is one of those subpopulations that maybe we're kind of swaying what we're deciding how to treat those folks. So a couple of key points from this paper. Median survival about 6 months, so a little bit better than some of those historical controls. Didn't matter what histology it was. If you got surgery, you did good. What did matter is if you had no extracranial mets. Clearly your survival was better if you had no extracranial mets. This top curve is patients with a KPS of greater than 70, so clearly you had a better survival if you presented with a good functional status. And important to me, and something that we really realized more recently, is that you do much, much better, your survival is significantly better if you get a gross total resection versus a subtotal resection. And if we have time at the end, I'll get into why that is the case. But the bottom line is that as surgeons who focus on brain tumors, we really feel like you shouldn't be taking these out unless you get a gross total resection. A partial resection has problems associated with it. So that's our goal, is gross total resection. So that's why we're always emphasizing, right after surgery, repeat the brain MRI within 72 hours, and if there's a significant residual tumor or nodule, we're taking that patient right back to surgery immediately during that hospitalization, and we're going to get that tumor nodule out. Now, there's always blood products. There's always maybe a little tiny rim of enhancement. There might be questions that a radiologist raises on those post-op MRIs, but we're looking for obvious tumor nodules that we missed during surgery. I'm going to keep going. This is another study that came out last year, another big retrospective review of surgery for brain mets. Important point here is, again, it's a selected surgical case series. Most of these patients got good gross total resections. Most of them got adjuvant therapy, such as whole brain radiotherapy. So a very well-treated population. Wow, median survival now 19 months in this particular population. Important thing I pulled out of this work, again, gross total resection is that red curve. So if they get subtotal resection, their survival is much, much poorer. Again, clinical, functional status when they present with a brain met, very, very important if we're going to select that patient for surgery. So in this left panel, in just the folks who got good gross total resections, those who had a really good functional status, for example, as represented by an RPA1, had a significantly better survival than those who did not. Since then, there are some randomized clinical trials out there that have been completed. Haven't seen all the data from those quite yet, but they're going to be very interesting results for us. So for example, here's two looking at surgery versus radiosurgery or stereotactic radiosurgery. So my hope is that these studies are really going to fine-tune which a subset of patients that we're having the big impact on that we really need to be selecting for surgery versus maybe other focused therapies like radiosurgery. I'll show you just a few examples to illustrate some of these points that I've been trying to emphasize. So over here on the left is that patient with a left-sided brain tumor. In this case, this top picture is a T1 MRI without contrast. It's bright, so that represents most likely hemorrhage. So this is a hemorrhagic met. And this sagittal view shows that it's right there in the superior and middle temporal gyri where we're worried about speech. So a couple of caveats here as a surgeon. Hemorrhagic tumor is going to make surgery a little bit more challenging. It's an eloquent cortex that I got to pull out some of those tools in the operating room to take that out. In the literature, a lot of people talk about, well, what is accessible? And I was trying to emphasize to you that from my standpoint, anything supratentorial is probably accessible. So this picture on the right is an example of something that some people would say, well, that's a deep tumor. That's not up there right at the cortex. It's much deeper. It's very cystic. It has this sort of central enhancing nodule. This patient we really thought was going to be a brain met based on his clinical presentation and history. And then after we got him to surgery and we took it out, this is just a residual resection cavity, we found out it was a malignant glioma, GBM. So emphasizing that what you highly suspect is a brain met may not be the case for that patient. Even if it's a tumor that we feel like surgery is not the right thing for them, we still want to really push for biopsies. Simple little needle biopsies. A lot of surgeons do those awake. They do it as an outpatient in a lot of settings. So easy to get that diagnosis to make sure that we're ruling out those other things that look the same, like abscess or gliomas. So a few tumors occur in areas that truly are really hard to get to. This top left one is a metastatic tumor to the pons. That only happens 1 to 3% of the time, so a bit unusual to have a metastatic tumor there in the brainstem. There are just a handful of folks out there who might actually attempt to take that out, but as a group, we pretty much have decided that trying to take out a malignant tumor in the brainstem is not the way to go, so we tend not to do that. That bottom left panel illustrates one of the problems of dealing with hemorrhagic mets like melanoma. So here's that patient post-op, and his resection cavity is bled, creating a major clinical problem for that patient that's really kind of hard to fix now. The right pictures illustrate another important point. So here's a patient of mine a couple months ago who had a colorectal met. So we see a very nice, discrete, ring-enhancing lesion on the MRI, classic picture for a met. But what's really interesting about this one is if you look at the T2 pictures, you see all this T2 signal in the brain parenchyma around that met. And that's that edema that's causing enormous mass effect and clinical problems for that patient. So we can do a good job at getting that out and just leaving a resection cavity. And very quickly, so this is an MRI about 2 months after surgery, you have a resection cavity full of CSF, but there is absolutely no more edema in all that surrounding brain. So it's not just taking the tumor out that helps with the mass effect, it's really stopping the process that's causing this massive edema that we often see in these malignant tumors. So nowadays, we're seeing cases like this. They're very challenging. So here's a patient who had non-small cell, 2 years out. He was just going through some surveillance imaging, found a single brain met, and for various reasons, that got sent for stereotactic radiosurgery. Several months after that, he presented with this lesion that looked like this, that was growing. Patient had worsening clinical problems. For him, it was really messing up his speech and causing bad aphasia. So this is not quite exactly like that prior picture I showed you. You can just compare that, to this, and you'll see subtle differences. So I don't know if that's growing tumor or a radiation effect. There's all this edema in the frontal lobe there. Again, I don't know if that's from tumor or radiation. So you can try biopsies, but in a situation like this, biopsies are tricky because there's so much heterogeneity throughout this area that if you don't get the right biopsy in the right spot, you're going to get a wrong answer maybe. So one thing led to another. He did go to surgery, resected the tumor, and you can see some reduction in that T2 signal. So clearly some of that was related to radiation, but some of it was also growing tumor, as we proved when we took it out and sent it to pathology. So trying to figure out how to deal with post-radiation patients, especially those who are getting focused radiation therapy, is a bit tricky. So take-home point. Clearly, there's good class 1 evidence that says surgery is appropriate for brain metastatic tumors, but it has to be the right patient. So some of the the things that we all agree on for surgery. It has to be a good candidate. You have to be able to get that patient through surgery. Now, we haven't agreed on exactly how do you decide they're a good candidate. I've talked about KPS numbers, RPA classification. I tend to ask my oncologist, what's your prognosis for this patient if I can successfully deal with his brain met? Is his prognosis, you think, going to be at least 6 months, 3 months? So various ways, but first of all, we have to make sure we get that patient through surgery and that they're going to have a good prognosis. Mass effect is a strong indication for surgery, as I've illustrated to you, especially in the posterior fossa, so back here in the cerebellum. There are some unique reasons why a very small tumor back there can cause enormous mass effect problems for a patient. Superficial or accessible tumors, and I've been trying to argue that really anything supratentorial I think is accessible. And then I put in here resection and one craniotomy. So a lot of the literature talks about single brain mets is the appropriate patient for surgery. Well, as neurosurgeons, we have decided that that's not really the best way to define it. We would rather define it as, can I get all of the brain disease out with just one craniotomy? So I don't care if it's one brain met or 2 or 3 or 4, but if I can do one craniotomy, then I will consider it. If I have to do a craniotomy on the other side of the head, significantly increases my time in the operating room, patient's time under anesthesia, very, very different scenario. So multiple craniotomies, we all agree, is not appropriate. But we'll certainly take out multiple mets if we can do it in one craniotomy. There are other things that people might look at for deciding whether or not surgery is the way to go. They're questionable and kind of depend on the surgeon. And I'll leave the discussion up about radiation therapy for one of our panels. So I want to emphasize to you as oncologists to always just ask your neurosurgeon. Don't go by what a radiologist is saying on a report. And I wouldn't even go by your interpretation of the surgical literature, because as surgeons, we have different tools in the operating room, we have different experiences, so it's often a very surgeon-dependent answer. So I want to encourage you to always be reaching out to the surgeon, at least getting their opinion. I understand, in the VA system it's difficult because you don't have neurosurgeons at all of your VA centers. In my vision, we have 2 centers that have neurosurgery. Only one of them really focuses on tumors, but of course there are thousands of hospitals and clinics throughout the VISN. So what I've tried to do is encourage those folks not near a VA neurosurgeon, to figure out a way to reach out to somebody either by email or through notes in CPRS, but try to, form a relationship with at least one neurosurgeon that you can always go to for just a quick opinion or consult.